This is by way of disclosures. I am a shareholder for 3D Biopsy, which does produce materials for performing transperineal biopsies. So what are the best candidates for targeted focal therapy of the prostate? Now this is just the ideal candidate. Should have a low grade, 3+4 or less. You know, if you've got 8 or above, probably a poor candidate for this modality. Tumor volume low, although high is not necessarily excluded. Unilateral, unifocal, again, not always an exclusion depending on how you design your scheme for targeted focal therapy, and low stage. But there are other factors that go into this as well. The therapeutic modality, what are we going to use? Is it cryotherapy? Is it HIFU? Is it electroporation? May go into the philosophy on how narrow your window for targeted therapy is. And then physician philosophy also pertains into this. I've talked to physicians who believe that targeted focal therapy should be considered a better alternative than active surveillance, while others say, well, no, it's really it's an alternative to more curative therapy. So what you're really asking is, do you think it's a modality for cancer cure or cancer control? And again, those are philosophical differences and are really going to add way into how your approach to targeted focal therapy is. And then there are different ablation strategies. Some believe that the only real targeted approach is a site-specific approach that you would see in D here. Others extend it to quadratic or hemiablation, and even extended ablation. Anything subtotal prostate therapy would be considered focal therapy. And in this case, always getting the index lesion, shown here by this big orange blob, but maybe picking up other significant lesions by extending the window as well. Notice that all of these have these little green spots all through here, saying that we can allow for the presence of low-grade, small-volume tumors that are not within the window of therapeutics. Now, here's as a pathologist where I have a little bit of concern about this, is how well can we define these low-grade contralateral areas using the tools that we have right now? How sure are we that this is the scenario that we're looking at? Well, certainly not using trust-guided biopsies. Systematic biopsies, as we know right now, sample cancer because they're a function of tumor volume to prostate volume ratio. So the smaller the volume of a tumor relative to the prostate volume, the more likely you are to miss it. Similarly, that could happen with high-grade tumor. Just because you have sampled 3-3 tumor in a needle biopsy doesn't mean that tumor doesn't have areas of 4 or even 5 within it, because you just simply missed it. Biopsy may not sample the highest grade or even the index lesion. In our prostate cancer database, we looked back and found that over 5% of the time, the biopsy really didn't sample the index lesion at all. Biopsy is a poor staging tool, as we know, and is really inadequate for precise tumor location. If you look at the SEER database, this is almost 26,000 patients from community as well as academic practices. You look at the rate of upgrading here, and this is stratified by PSA, which is a surrogate marker for tumor volume. And you can see significant upgrading of 3-3 tumors with subsequent prostatectomy, over 40% in most cases. You even get it with higher grade biopsies as well. And so this tells you that in the contralateral region of the prostate, you may not have good feeling about actually having only 3-3 low volume tumor present. And even in the index tumor, there's some problems here. If you look at this, this is a pathologically advanced disease. So this is upstaging with the biopsy parameters that we have here. And you can see a significant rate of upstaging, really, of the index tumor here with the normal trust biopsies. So we have some concerns applying these old tools to focal therapy. How can we accurately assess tumor grade and aggressiveness with the tools that we have? Tumor extent, including multifocality, volume, location. And then once we know this, once the location is known, how can we precisely deliver targeted therapy to that area? So we have some potential solutions. What's done in our institution is to increase precise sampling. We do this using transperineal template-guided mapping biopsies. Now, this is more than just a saturation technique. This is precise mapping using a template-guided approach here. If you put a grid, the usual brachytherapy grid right in the perineum here, and we go across and you play a big game of Battleship, right? And you basically sample across, down, and through the prostate every 5 millimeters. So it's really kind of like a game of Battleship here. You know, this is your truss biopsy, doing shots in the dark in the hope that you'll sink a ship. Here, we pretty much saturate the grid with shots, and we can define every ship and sink them all. On our early pilot studies looking at the feasibility of this, we went backwards. We looked at our reconstructions that we showed you yesterday, or I guess it was 2 days ago, our whole mount reconstructions here, and then really looked at how we could place these needles in to better define and more accurately define what we would find on prostatectomy. And it was using a reverse reconstruction model that we found that the 5 millimeter interval seemed to be the best interval to really get accuracy here. The only thing that really wavered here was our volume estimates were off by about plus minus 15%. In these tumors. Otherwise, even these small foci up here could be detected using this approach. This is what we receive. We have a kit with a gazillion vials, and they all come to us. To conserve cost, we differentially ink these and put them in cassettes. Once you have the cassettes, they're actually reported by grid line, not by relative location of apex base, etc. We actually do the grid line here. And you'll get a big report like this on a table, and there'll be some of these that are positive and most of them are benign. It's one of the big problems here is the cost effectiveness. Most of the biopsies that we get in pathology are going to be benign cores. Yet they still cost us to process them and report them. Once that's done, we have software that can redistribute these back, actually reverse reconstruct, if you will, the prostate superimposed on the truss image here. You can see the positive cores here outlined in red, and there's some other cores here in a different plane, and you can look at it in the longitudinal aspect as well, and find a region here that it qualifies for focal therapy. Our relative resolution here is we can feel confident that we'll find tumors less than 0.042 centimeters. So that's pretty darn small tumors that we're able to detect here. And here it's superimposed back on the truss image here for localization for therapy. We've compared, this is our early data comparing the template-guided mapping biopsies with the truss-guided in 215 patients. See the median number of cores is significantly higher here with template-guided biopsies. But notice here what happens with Gleason score. We felt in the truss biopsies that the vast majority of these patients had Gleason 6 or below tumor. And you can see the redistribution, 40% of them were upgraded on truss biopsy, some of them significantly upgraded even to Gleason pattern 9. This is data from the European literature, very similar. They, instead of just looking at grade alone, they looked at risk, which included grade and percent core, the volume of the tumor on the core, into low intermediate risk. And again, truss biopsy, the vast majority of their patients were either low or intermediate risk, and you can see that they were reshuffled with template-guided biopsy. Most of these were increased even to high risk. So only 1% were thought to be high risk on truss biopsy. That rose to over 40% when you did template-guided biopsies. This is a multi-institutional study that, again, looked at the positivity rate after negative truss. You can see 56% of their patients had positive cancer on template-guided biopsy after a negative truss. And they actually, even after 1 or 2 negative biopsies here, and what they've done here is actually look at the location of the tumors, where those were located and why they were missed. And as you can see, there is a preponderance of either anterior tumors or deep anterior-posterior tumors in this area, and that rate went up as the rate of negative biopsies was found. Now, we have correlated our template-guided biopsies with with prostatectomy data. This is again our early data showing our first 25. And it was much more likely to be upgraded from the transrectal grade truss biopsy versus the transperineal biopsy grade. This is the data from the European literature. They do things a little bit different in the European literature. Instead of the technique that is every 5 millimeters across, down, and through, they separate the prostate into 20 different segments, sectors, and then they take one or more biopsies from each of those sectors when doing their transperineal biopsies. So it's a little different, but very similar data here. You can see that 22% of their patients diagnosed by truss were upgraded on final pathology of the prostatectomy versus only 14 diagnosed by template-guided biopsy. That's not the only method. We'll hear a lot more about this morning, but you could add imaging, specifically multiparametric MRI can use in this setting. And from my point of view, it's been very confusing looking at the literature, and this is just a few of the reports that look at cancer detection by fusion biopsy. And you can see they differ in terms of their N, usually relatively low N, field strength 1.5 or 3 Tesla, and now we're going to see data involving 7 Tesla, I think, pretty soon. Whether or not they used an endorectal coil, they even used different definitions of a significant lesion on MRI, either PIRADS 3 or above, in some cases PIRADS 2 or above, others PIRADS 4 or above. And they even used a different definition of what they called clinically significant prostate cancer. Some just used the largest lesion regardless of grade. Others used biopsy results, either Gleason 7 or high volume Gleason 6. Others really worked backwards and looked at the prostatectomy grades and worked backwards in terms of extra prostatic extension, Gleason score, tumor volume, et cetera. But they all show sensitivities ranging anywhere from 85 to almost 100%. But specificities that were on the low end here. Another way of looking at it, this is a recent study just published this year, is to look, when you compare your prostatectomy with your MRI plus truss biopsy and say how concordant are they in determining eligibility for focal therapy. And that's what this study did. They looked at eligibility defined as 3+4 unilateral tumor for focal therapy here, and they determined that in the radical prostatectomy, and then looked backwards and said, based upon their pre-surgical multiparametric MRI plus truss biopsy superimposed, how many were eligible? With the sensitivity, it was fairly reasonable, almost 73%. They were able to find those that were eligible. And the specificity, which was pretty good, meaning that if they deemed you ineligible by multiparametric MRI, you were probably ineligible on final pathology. But the positive predictive value was only about 60%. So you missed about 40%, or about 40% of the cases that you thought on multiparametric MRI were eligible for targeted therapy actually proved to be ineligible on final pathology. And why is that? This is a table from that paper that showed you did pretty well when you define the index tumor. Only 9% of their cases were upgraded to 4+3 or higher on the index tumor. But it was in the negative side, in that contralateral lobe that we had the problem. And you could argue that they defined that too rigidly. They had a PIRADS 3 or below was being negative, plus no cancer on your truss. But their false negative rate was about 70%, and some of these were significant grade as well. You can look at a few papers that have compared multiparametric MRI with template-guided mapping biopsy. These both come from the European literature. A study of over 14 patients, they found that of 124 with a negative multiparametric MRI, about 26% of them were found to have clinically significant cancer defined as 3 or 4 or above on template-guided biopsy. This biopsy program, again, used the Barzil's system, but again, they found similar results, and about 36% of theirs with a negative multiparametric MRI had cancer on the template-guided, And of those, about 70% were found to be significant. 30% had Gleason 7 or above, and the majority were anterior tumors. In a more recent study here, again, over 400 patients, they looked at the area under the curve using template-guided mapping biopsies as the reference for a multiparametric MRI, and found a decent area under the curve of about 0.75, again with higher sensitivity than specificity. So it appears then that template-guided mapping biopsies are a bit more accurate in terms of finding all the biopsies than multiparametric plus fusion biopsies. But there's a trade-off, isn't there? I mean, there's a lot of cost. There's OR time in terms of doing template-guided biopsies. There's inadequate materials. We hope to change that at some point for doing that. And there are reimbursement issues for pathologists in terms of looking at these. And those are the trade-offs that you find by doing those kind of things. A little word about monitoring. Pathologists also get involved in the monitoring of patients after targeted focal therapy. In our institution, we sort of monitor as active surveillance. We follow up with PSAs and follow-up biopsy at a distant site. Now, in our institution, it's annual. We'll do a 1-year follow-up biopsy. Others vary on the time. And that biopsy is usually done just simple truss 12 core. Others have used multiparametric MRI plus truss in this setting and found that to be an accurate way of monitoring efficacy. What's a little bit unclear now is there a role for biomarkers in this space? Perhaps using biomarkers as an indication for rebiopsy rather than just going ahead and scheduling a biopsy 12 months down the road. Either using select MDX, 4K, Phi, some of the things that Dr. Crawford talked about earlier this week. And if you do find cancer detected on a follow-up biopsy, the vast majority in our institution have found to be 3-3. But is there a role for using cell cycle progression score, the Prolera study, or the Oncotype DX or something similar to determine whether or not you have aggressive disease elsewhere? The problem with this is there's really no good level 1 evidence at this time to support the use of these, but it adds an interesting question to this. So I'm going to conclude here by saying the pathological features are important for appropriate patient selection for focal therapy. We need to consider grade, volume, and location. Traditional transrectal biopsy schemes are completely inaccurate for this. Transperineal mapping biopsies offer improved pathological accuracy. And the combination of multiparametric MRI with truss fusion biopsy is useful for determining eligibility for focal therapy, but may underestimate tumor burden, particularly contralateral tumor burden. We have some anticipated improvement with 7T that remains to be seen, and the use of biomarkers in patient selection is yet to be, and monitoring has yet to be determined. And I'll end there. Thank you very much.